the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Hello, everybody, and welcome back. My name is Chuck Dowell. Another interesting case that we had in the Ortho Urgent Care this week, which I thought would be fun to share. We had a 2-year-old. The parents brought the patient in complaining of lack of use of the left arm. The mother states that the night before, she was playing with her brother, who was her older brother. They were holding each other's hands and swinging each other around. And then immediately she started to kind of complain and or not use her left arm. They tried to treat this conservatively with anti-inflammatory medications and rest. She didn't sleep well that night. They brought her to our orthopedic urgent care the next day for evaluation regarding this. According to the mom, there was no previous injuries noted to the left elbow. She's otherwise a healthy 2-year-old. In our urgent care, because sometimes we're busy, our medical assistants do an evaluation of the patient and then discuss and or decide if x-rays needed to be ordered. For this patient, because she was a 2-year-old complaining of elbow pain, x-rays were ordered. I did see her after the x-rays. Interestingly enough, upon me entering the room, I noticed that she was using her left arm quite well. She was actually using it to hold on to her mother. She pushed herself up in her mother's lap a few times while using it. I examined the elbow. According to the mom, prior to the x-rays, the patient would not use the arm at all. She would not bend or straighten the arm, didn't want anybody to touch it. Actually cried quite a bit during the x-rays. I examined the elbow. She didn't react to any tenderness and or palpation throughout the elbow. In a 2-year-old, sometimes it's hard for them to verbalize pain, so oftentimes I'll examine while I'm watching their face to see if there's any reaction or grimace on their face, or a lot of times they'll retract to palpation within the area of tenderness. So usually in kids younger than 2 or 3, I'll oftentimes not rely on verbal communication to let me know if there's any tenderness or the area of pain, but I'll look at their face while palpating and see if they retract the extremity while palpating to any specific area, which is usually a sign of this is the area that's painful for them. So for her, when I was examining her, she didn't retract to any palpation throughout the elbow area. Based upon the mechanism of injury that the mom was telling me, I thought possibly she had a nursemaid's elbow, so made sure to really palpate throughout the lateral elbow area quite significantly. I then tested her range of motion gently at first because, according to the mom, she did not want to use the arm at all. So initially I just had her hold the arm at 90 degrees of elbow flexion, and then I tried to pronate and supinate the hand and wrist to the maximums. She was able to tolerate this without pain or grimacing or retraction. I then flexed her elbow up to full flexion, full extension. And again, she tolerated this quite well without any significant symptoms. The mom was quite surprised. She states that prior to the x-rays and prior to me coming in the room for the examination, she would not use the arm at all, would not let anybody touch the arm. And then as we talked, and I talked with the mom over the next 5 or 10 minutes, I could see that she was using the arm more. She walked out without any concerns, holding her mom's hand with the left arm, again, without any concerns. So I think what happened in this case is, in her age range with the traction injury and the immediate pain and lack of fall, and mom states this was witnessed, so there is no concern about unwitnessed fall. That would make you think of a differential, as in a fracture of the elbow. She likely had a nursemaid's elbow. Because we obtained x-rays, and one of the positions of the x-rays is to get her into a hyper-supinated position for evaluation of the AP of the forearm. I heard her crying during the x-rays during this time, so likely this hyperpronated position with her kind of crying or being fussy reduced the nursemaid's elbow for the patient. So this was reduced prior to me coming into the room. I thought an interesting case. I do see this not unfrequently, that these nursemaids' elbows are reduced prior to me entering the room. If we do get x-rays beforehand, oftentimes if I see the patient or hear the history, I'll hold off on the x-rays because they're often not needed for these nursemaids' elbows. And I'll just do a clinical examination. And during the examination, I'll try the reduction techniques and see if I can feel the pop or click. These are definitely one of the more satisfying pediatric elbow injuries to have because it's quite relieving to the parents and the patient that you're able to manipulate the arm, and after the manipulation, they use the arm without any concerns. This was her left arm. Some of the literature does show that left arms can be more common for these types of injuries, possibly because oftentimes they happen due to traction injuries from the parent pulling on the child's arm, and most of us are right-handed, so we hold on to the left arm of the child. So just to review, if we remember, these nursemaid's elbows typically happen commonly in children from 1 to 4 years of age. Some of the literature shows that the average age is about 28 months. It's pretty rare after 5 years of age for these to happen. There's a slightly more and or increased predominance for these to happen in females compared to males. Usually the mechanism of injury is a longitudinal traction. They can happen from a fall on an outstretched arm as well, but again, typically a longitudinal traction type injury that frequently causes them. There's a few different theories as to why these nursemaids' elbows happen and are frequently happen. Again, we don't know, but some people think that it's the smaller size of the radial head in relation to the shaft, and the fact that the annular ligament is thinner in children, especially under the age of 5, is why this more frequently happens. There is some predisposition to children that are slightly above and are elevated weight for their age, possibly again relating to the traction and the aggressiveness of the pull or the weight of the pull potentially causing these. Originally, they were described as radial head subluxations or dislocations, but again, the more anatomical or appropriate terminology would be annular ligament injury. So the annular ligament becomes interposed between the radial head and the capitellum, and oftentimes this is what causes it to happen. Sometimes in the history, they can hear a click, but frequently when I've seen these in the past, it's often a child who just refuses to use the limb, holds it in a slightly flexed position. A lot of the times the forearm will be slightly pronated and they'll react and or grimace to palpation diffusely throughout the lateral aspect of the elbow. Again, radiology is not necessary to confirm the diagnosis. They have shown that 25% of the time, the radiocapitellar line will be slightly lateral to the center of the capitellum. Ultrasounds can be used quite frequently. They do have a pretty good specificity and sensitivity regarding these nursemaids' elbows, but again, these are often reserved for patients where you try these reduction maneuvers or techniques and potentially they don't work, and then you can get the imaging to ensure that there's no evidence of fracture and or the ultrasound to see if there's interposition of these annular ligaments, and potentially that's not being reduced by these reduction maneuvers. Differential diagnosis, as we talked about, there's no trauma associated with these. Oftentimes, if it's an unwitnessed fall and the patient comes in with limited range of motion, I may be less prone to manipulate the elbow prior to getting x-rays because, again, not sure if the patient had a fall and has some type of supracondylar fracture causing the limited mobility of the elbow. If it's a witnessed kind of traction type injury to the elbow, then oftentimes we can hold off on these x-rays. Radial head dislocations, forearm synostosis are always possible. Radial neck fractures, lateral condyle fractures, olecranon fractures, and supracondylar fractures, again, are always possible, but these would be more consistent if the patient had a fall to cause the potential onset of symptoms. So for reduction maneuvers, oftentimes there's two types of maneuvers you can use. The supination technique, I think, is the probably more common one. The provider holds the elbow at a 90-degree flex position. You try to put your thumb over that radial head area. You hypersupinate the hand and or wrist at this 90-degree flex position, and then you move the arm into maximal flexion. And oftentimes you'll feel a palpable click or hear a palpable click when the reduction of the radial head is noted. You can also try hyperpronation technique, and involves, again, taking the elbow flex at this 90-degree position and pronating the arm into the extremes of pronation, again with the one hand palpating the elbow and the lateral aspect of the elbow, again oftentimes feeling a reduction and or click. I would try both techniques. In my experience, typically the supination technique works the best, and so I usually try that first, and oftentimes I can do this when just checking range of motion of the patient. If I think the history is consistent with concerns for a nursemaid's elbow, if this doesn't work, then I may try this hyperpronation technique. From a follow-up perspective, Ideally, you keep the patient there for 5 or 10 minutes. Typically, within 5 or 10 minutes, they should go back to completely normal use of the elbow, using that arm to push themselves up with full motion of the arm. Oftentimes, the patient or the baby will be less fussy, and that typically shows you that the elbow is reduced back into position. You can consider possible immobilization, but often unnecessary if it's the first episode. Typically reserve this if multiple episodes have happened. These episodes can occur more often, especially in children under the age of 3, and the initial treatment with multiple episodes of this can be cast application and a flexed and neutral or supinated position of the elbow to provide that elbow in a more stable position. If the elbow is unreducible, you can put this patient into a posterior mold splint, have them follow up with your children's orthopedic specialist. Sometimes this will require open reduction in the OR. Again, imaging could be provided at that time, including ultrasounds. If you do have a good musculoskeletal ultrasound available to you, that can help to see if there's interposition of this anterior ligament. So I think this is really an interesting case. Again, I've seen these in the past quite often where they'll be reduced prior to me seeing the patient. The patient does feel satisfaction and symptom relief quite soon after the reduction is performed. And so it is definitely a satisfying one to do. I thought this was a fun and interesting case to review regarding pediatric elbow pain in a 2-year-old female.
Listeners, I appreciate Chuck Dowell being on, and he has his own podcast called Ortho on the Go, and it's a clinical-based discussion on orthopedics. He has a lot of relevant information. I hope you'll go to listen to that. Again, it's Ortho on the Go with Chuck Dowell.